Any questions from the video? It feels like they know. I don't even know what we talked about. Angina. What else we talk about?
I have a question.
Yes.
General question.
General question. Okay.
Slides that you don't really spend too much time on. Should we still go back and memorize that stuff, or is that
memorize everything I say?
Everything you say.
Mm-hmm.
Just like, I'm asking because there's some parts that you went over really good. You were kind of like, okay, like kind of.
Yeah. So if I spend a lot of time on it, chances are that's the things I'm going to be more focusing on. You know, like I'm trying to hit the broad concepts. I'm trying to hit the kind of the major things I want you guys to know, versus like all the kind of the minutia, right? So some of those things are on there just to either prove points or kind of help accentuate things. But you know, if I blew past on a slide, chances are I didn't feel like it was important enough to really talk about that long. You're less likely to see that on a test. Not to say you won't.
Right.
Less likely, right? Okay. Any other questions? All right, so test should be next week, so hopefully we'll get through all the material today, and then, I don't know, we may or may not have time for review. We shall see, but we'll see how fast we get through this. Anyway, so we're talking about chronic heart failure, congestive heart failure, however you want to call it. So how do people get CHF? What's happening? Have you guys talked about that in other classes yet? Okay, so what's kind of the etiology here? What's happening? You guys explain to me.
Heart strain.
Heart strain? Okay, so the heart's straining. What happens to that muscle when it strains? Hypertrophies, absolutely. So hypertrophies, what happens to a hypertrophied left ventricle? It's stronger muscle. It should be beating better, right?
No, it can't hold as much blood.
Good. It gets stiffer, right? So it's harder for it to relax and hold as much blood, right? So we're going to talk about diastolic versus systolic heart failure. How does someone develop? Why does that hypertrophy happen? Why is their heart strained? High blood pressure, right? So the pressure the heart's pumping against is very high. What do you term that? Afterload, right? So the afterload is going to be really important to talk about. And then what's preload?
The amount of blood in the ventricle before.
Right, so blood's a return back to the heart, right? So the amount of blood you have coming back, and a lot of that is dictated by fluid status, has a lot to do with venous compliance and how much fluid that's holding, and how much is kind of sending back to the heart. So anyway, so the other big thing is after you have an MI, right? After you have myocardial ischemia, what happens to that tissue that was ischemic? Kind of dies off, right? So it doesn't just regenerate like other, if you cut your tail off, like all of a sudden that would grow back. I'm sure you guys all have tails, right? Sorry, it's me and lizards. But you would see that tissue comes back and it's very fibrous, right? It's kind of that scar tissue that's there, and it's not super compliant as well. It doesn't really beat that well, and so this is why we see arrhythmias that happen after MIs. We'll talk about antiarrhythmics a little bit later, but it's also why the heart's just not really beating that well. And so kind of the big thing you see with CHF is, how do you measure that as far as how well the left ventricle is working? Right, ejection fraction. It should be lower when you have CHF. Good. So anyways, I'm not going to cover all this. Just know that there's lots of different reasons you can have CHF. You can have cardiomyopathies related to things like viruses. Alcoholics tend to have a higher risk for this. You can even see certain drugs can actually induce this. When we talk about chemotherapy next semester, I believe, we'll talk about some drugs that actually can cause this. Even though they are life-saving in the fact they can cure cancer, they can also damage your heart kind of irreparably. So we'll talk about some of those things as we kind of come upon them. So anyway, so again, we know this is due to loss of that myocardial muscle mass, or we have this left ventricular hypertrophy, so it gets stiffer and not really able to relax as well. And again, it's going to be assessed by this kind of reduced ejection fraction. So I won't kind of belabor these points because you've covered them elsewhere, but we'll talk about the drug therapy, why it's so important. The other big thing you see here is this diastolic dysfunction. That's going to be an issue with kind of the impaired relaxation. That's where it has a difficult time actually relaxing, allowing more volume to fill the ventricle so that can contribute to the cardiac output. Right? Systolic heart failure is more to do with that increased afterload you're trying to pump against, right? So it's the extra pressure there. So let me just go and get to, right, so the other thing we're going to see here, when you have poor cardiac output, how does your body respond to that? So you can't really pump out enough blood, right? You're not getting enough, say, oxygen-rich blood to the tissues where they need to go. How does your body respond to that? Increase heart rate. That's one way we can do it. What else? Yeah, so fluid retention is a big thing, right? So where does renin get released from? We talked about the renin-angiotensin system. Kidneys, yeah, the kidneys is a big place where that gets released from, right? So when the kidneys detect we don't have enough pressure, right? So because again, your body's trying to pump blood to the kind of vital organs, so the brain and the heart primarily. Kidneys might take a kind of a back seat to that, and so they detect low blood pressure. They're going to detect we don't have enough salt and water here. Let's go ahead and hold on to that. And so it can do that by which mechanisms? What kind of hormones help with that? ADH, yeah, antidiuretic hormone is going to be an important thing with that. And what else? Aldosterone's another big one, right? So we're going to see these components who are going to be exacerbating our CHF by increasing the amount of fluid we're holding on to. And what does that do to our preload? It increases it, right? What does that do to the strain on the heart? Increases it, right? So you can see how there's kind of a cyclic pattern to this, and how kind of heart failure kind of begets more heart failure as it goes on. And that's why a lot of the drugs we're going to use, the things that will show improved mortality, are going to be things that help to slow the progression of disease, right? So these are going to be things that try to interrupt that renin-angiotensin system. These will be things that try to interrupt aldosterone effects and things like that. So kind of keep that in mind as we go through and look at this. So if you imagine if you had heart failure, you have a poor left ventricle activity, you're going to have lower cardiac outputs. That's going to do things like increase venous volume and pressure, right? Because you're trying to, if your cardiac output's going down, then TPR has to go up in order to compensate for that, to make sure you're getting blood to the right areas. So again, that can lead to things like congestion and edema. We know they have fluid overload. It's kind of a chronic problem in CHF patients. That can lead to things like dyspnea and orthopnea. Seeing here the decreased tissue perfusion, that's where you can see a lot of exercise intolerance for these patients. Like that's one of the things we're kind of judging how progressive their disease is how much exercise tolerance do they have, right? So do they get totally winded and done by the time they get to the door, or can they walk to the elevator, right? These are kind of things you're looking at as well. And of course, some of these things kind of compensatory responses like the sympathetic nervous system, renin-angiotensin systems. We talked about that already. But again, all this is kind of a sick cycle where it's going to kind of feedback on itself and worsen the heart failure. I do some of these tables, and you're not really don't like these PowerPoint presentations at all. Apologize for the delay. I know it looks okay up there, but a black screen over here. As soon as this works, the helicopter is going to try to take off. I guarantee you. Oh, come on. There we go. All right. So anyway, so certainly there's lots of signs and symptoms associated with CHF. Certainly you can have left-sided symptoms. You can also have right-sided symptoms depending on kind of the variety of heart failure you're dealing with. I'm not going to cover this quite so much, but just note that a lot of these symptoms are due to kind of volume overload. And so one of the things we're going to be focused on for therapy in ways that we can improve symptoms is try to get rid of that extra fluid. How can we do that? Diuretics, right? Diuretics are going to be kind of our go-to drugs to help with that fluid overload. So some things that can precipitate decompensation. When I say decompensation, what does that mean? Someone has a CHF decompensation. Yeah, so it's an acute worsening of their CHF, right? So maybe they're not able to oxygenate very well. They get very fatigued, very tired. Their cardiovascular status can go pretty wonky, where they're not really able to perfuse the tissues very well. This can be potentially deadly, right? So this is one of those things where you need to get the patient into the hospital to give them things like drugs that will kind of kick the heart into gear, try to increase inotropy, things like that. But you can certainly see things like lack of compliance, either with medications or certain like dietary restrictions, which we'll talk about in a second. Things like arrhythmias or uncontrolled hypertension. All of these things can predispose someone to having a decompensation. And again, patient education is super important here to make sure that they're being managed from kind of all aspects of this. But other things can happen as well. Certainly emotional stress, infection, all those things can also kind of tip a patient over into having one of these decompensations. So you deal with things we have to keep patients out of the hospital as best we can, and we can do that with some of our medications, which we'll see here. As far as non-pharmacologic therapy goes, fluid restriction and salt restriction are going to be a big thing here. But again, when you have ADH, antidiuretic hormone being secreted, what does that kind of trigger in the patients? Thirsty? Yeah, they get really thirsty, right? I had one patient who, you ever heard of SIADH? It's a syndrome of inappropriate antidiuretic hormones. Sometimes you can see that patients have a head injury. I had a patient in the surgical ICU, had a car crash, had a head injury, had this really bad SIADH, and basically she was getting very hyponatremic, and one of the treatments for that is actually restrict water and salt intake. And I'd never seen someone try to lie, cheat, steal to try to get Gatorade so bad in my entire life. Like, they were sneaking out of the room. They'd put people at the door to make sure they didn't sneak out. They were trying to bribe family members to go get Gatorade for them. You just never seen someone who just needed something so bad. So it's going to be a very powerful stimulus, which is why people have a hard time kind of sticking with dietary recommendations, because they have this kind of internal need to have it met. You can also look at things like increasing physical activity. A lot of times, having someone who's kind of sitting around, kind of a couch potato, this can kind of lead to a lot of these issues in the first place. So again, getting them off of their feet, getting them walking around is going to be the best thing. All right, so as far as diuretics go, we're going to see that thiazide diuretics, while they are going to be good for hypertension, and it's kind of one of our first-line treatments for hypertension, they're not really good as far as potency goes for getting rid of a ton of fluids. They're not really good for symptomatic management of CHF, but certainly can have loop diuretics are going to be very, very good. Because again, loop diuretics are working where? The loop of Henle, right? So the loop of Henle, and they're going to be very, very potent. They get kind of the most bang for your buck as far as volume loss for his patients. So if you have someone who's having pretty significant peripheral edema, if they're having really bad, dyspnea, things like that, where they just had these really kind of junky sounding lungs, like all that's good signs they need to have a diuretic on board to help get rid of some of those fluids. Loops are going to be your best bet. Again, this is not going to help improve mortality at all. This is only for symptomatic management. Some patients will be on this stuff all the time. Some patients may only be on it as needed in order to help get rid of that fluid. So again, what's another good way you can measure fluid status in a patient kind of day to day at home? Yeah, you can weigh them. So again, if they're monitoring their weight and it's going up by a pound or more every single day for a few days, that's a good sign they're holding on to more fluid. They probably need to use their diuretic. So this may be one of those things where it's more PRN. Some of it is going to be more daily, depending on the patient you're dealing with. But again, looking at symptomatic management, this is one of the go-to drugs for that. You guys remember any of your loop diuretics? Lasix is one. You have a generic for that one? Furosemide. What else? Bumex, or was it generic for that? Bumetanide. That's the thiazide, yeah. You also have torsemide and then ethacronic acid are the other two, right? So those are kind of your four main loop diuretics. And it's not mandatory. We're really only going to be for patients who really had that fluid overload issue that they're trying to deal with. And again, if they're having those symptoms of fluid overload, this is the drug to go to. Now, ACE inhibitors are going to be one of these cornerstones of therapy. Almost every CHF patient you have needs to be on either an ACE inhibitor or alternatively they could be on an ARB, right? So those are kind of therapeutically interchangeable. Either of these are going to be fine, right? So this is useful because ACE inhibitors, what do they ultimately decrease production of? Angiotensin II, which we know to be a vasodilator, vasoconstrictor, potent vasoconstrictor, right? So this is going to help to decrease preload, helps to decrease afterload, helps to decrease some of that sympathetic activation, which is also increasing our blood pressure, and also is going to help with this remodeling. We kind of mentioned this when I talked about MI. This helps to prevent some of that left ventricular remodeling. So this does have proven mortality benefits for these patients. They need to be on some sort of angiotensin blocking sort of drug, either an ACE inhibitor or an ARB is totally fine. So this will help with the left ventricular hypertrophy, the dilation, remodeling, all that good stuff. And so, and again, can you reverse any of this damage that's done to the heart? Unless you get a transplant, you're not really going to be able to regenerate that tissue unless there's some kind of advancement in stem cell technology or who knows what could happen down the road. But nowadays, we don't really have anything that's good for that. But we can at least slow down progression, hopefully keep these patients alive for longer. So again, we get hemodynamic benefits, so their blood pressure is going to get controlled, hopefully. They're going to have improved exercise tolerance, decreased heart failure symptoms, fewer hospital admissions. All these things have been shown in large studies. So this is why these are kind of our cornerstone of therapy for these heart failure patients, okay? So if you had like a case that came up or a test question that came up and you have a CHF patient who's not on an ACE inhibitor or an ARB, that's going to be one of your first interventions to get them on that, right? And again, I'm not being paid by any of these ACE inhibitor companies, but we just know that it works, okay? So some issues. You remember how we talked about how ACE inhibitors can induce renal dysfunction for some patients? How does that work? Remember the afferent and the efferent arteriole, right? Which one does the angiotensin II work on? Efferent, right? So it's coming out of the glomerulus. So right, so it's causing a constriction. If I have someone who's really dependent on the angiotensin II to keep that GFR up, that filtration pressure up, if I relax that all of a sudden by giving too big a dose of ACE inhibitor, you can see an acute decrease in kidney function, right? It's not a permanent thing for most patients, and it's only for those who have kind of pre-existing renal disease in the first place. So for those patients, you have to start at low dose and kind of gently titrate up, right? Watch out for hypotension. Some people are going to be more prone to that than others. And again, why do we have a serum elevation or potassium elevation in the serum for these patients? It spares potassium. How does it do that? Yep, so it's going to promote or inhibit aldosterone. Right, so it's inhibiting release of aldosterone, so that's ultimately going to help us to get rid of more salt in the urine, but it's going to hold on to more potassium, right? So in that case, it could be considered sort of potassium sparing. And again, keep in mind, because if you look at like a loop diuretic, what does that do to your potassium? It's going to waste it, right? So you can get rid of potassium versus an ACE inhibitor. This can be a nice counterbalance where you can actually hold on to more potassium. Patients have kidney dysfunction. What's likely their potassium going to do? It's going to go up, right? They hold on to more potassium. So you have to be careful with these and make sure you're kind of balancing it out. The patient's, potassium is already 5.5. This might not be the best drug to start with, right? So maybe one of those things where you got to be very careful with that, because too high a potassium can lead to what? Arrhythmia. Yeah, so you can kill somebody with too much potassium, right? So you got to be very careful with that. Obviously, other side effects, cough, angioedema, we know that to be due to the bradykinin buildup. How can I avoid these issues? Or maybe minimize the risk? Give an ARB instead, right? Because you don't have that bradykinin effect here, so you get rid of that cough and hopefully have a lower chance for angioedema. Okay, the other thing, beta blockers are also going to be a cornerstone of therapy for heart failure. There's actually three main ones that we have studies to show that we can improve mortality for these heart failure patients. That's kind of counterintuitive, because you would think, what does a beta blocker do to the heart? Slows it down. What does it do to contractility? Decreases it, right? What do these patients have a problem with? Contractility. So it seems kind of counterintuitive to add on a beta blocker, but these are one of those things where by giving small doses, and generally you're going to start this like in the hospital, so you can watch and make sure they don't decompensate. You're going to start a very low dose and gently titrate up to get to a reasonable dose here. So the three ones that we have proven mortality benefit with are going to be carvedilol, metoprolol, and then particularly the XL formulation. So if you ever hear Toprol XL, that's that brand name there, and then this bisoprolol. Okay, so three ones you're going to give, and again, you really need to be very stable prior to starting this, because again, it's going to cause a decrease in cardiac output, acutely. And then over 6 to 8 weeks or so is when you're actually going to get them up to target doses. So you start them off low dose in the hospital, preferably, and then when they get out, this is when you can kind of start to continue to ramp it up. And then obviously you're going to be monitoring for worsened signs and symptoms of heart failure. So the things that we see, the reason why we think this is beneficial is because, one, we can see improved exercise tolerance. Essentially, if you think about the heart, you're kind of slowing it down. You're giving it more time for the left ventricles to fill, right? You're kind of helping to slow down that disease progression. They have shown there's decreased hospitalizations, decreased mortality, decreased need for transplant. All these things are really good for your patients. And so it's one of those things that, even though it's counterintuitive, studies kind of back us up in thinking that, yes, we should use one of these three beta blockers. Okay. So again, first-line therapy for class 2 through 4 heart failure. So again, pretty much the majority of patients, except those that are kind of very early on in the disease, should be on one of these. And so, irrespective of the symptoms, they should be on some sort of ACE or angiotensin II kind of blocking drug and a beta blocker for the most part. Unless they have some kind of really bad contraindication to using either of those. Okay. Next up, we have a drug called Digoxin. We'll talk about this again when we get to the antiarrhythmic section. This is actually kind of a steroid-based molecule. You can kind of see that steroid structure here. And so it's been around for a long time. Does anyone know where you find digoxin in nature? Any plants you can find it? Yeah, so digitalis is another kind of very similar drug to digoxin. Where do you find that at? Anyone ever heard of foxglove? Yeah, so foxglove is a famous plant where digoxin was originally came from. And back in the day, do you guys know the old term for CHF? Used to call it dropsy. That was like kind of like back in the very, very early days of medicine. But used to give this plant extracts of this foxglove to these patients and actually help with their symptoms. Other plants you can find it all along like the medians in Florida, along the highways. You can see that oleander is another one that actually contains digoxin-like structures in it. So that's why it can be very dangerous for kids or animals to get into. But regardless, it can be decent for CHF. Basically what this does, imagine this is a cardiac cell here. You guys have heard of the ATPase sodium potassium pump before, correct? What does this pump do for us? So this is a very important pump, right? We see it in use everywhere, from nerve tissue to heart tissue, all kinds of tissues. This is a very, very important pump because it is shuttling sodium, 3 molecules of sodium, outside of the cell against its concentration gradient, right? Because what's a normal serum sodium concentration? Like 135, yeah, 135, 140-ish. That's kind of a typical range here. So again, the intracellular concentration of sodium is generally pretty low, but it's going to be shuttling against the concentration gradient. To do that, what do I need? I need energy, right? So I need ATP to do that. That's why it's a sodium potassium ATPase pump. On the other hand, it's going to be shuttling potassium, 2 molecules inside of the cell, right? And what's the normal serum potassium concentration? 3.5 to 5 is generally considered a pretty good range. The intracellular concentration of potassium is much higher typically, so it's going to be more close to like 130-ish, 135-ish, kind of similar to sodium on the outside of the cell. So again, this is against the concentration gradient. So normally this is happening kind of all the time. This helps us to maintain that resting membrane potential that all of your myocytes are going to be sticking at, right? So again, every cell is going to have a degree of electronegativity to it, and that'll be important when we get to the antiarrhythmics here in just a little bit. Digoxin is going to come along and it's going to poison this pump here, right? Basically, it's going to shut it down. And so what is this going to do to the intracellular sodium concentrations? Well, you're shutting down this pump, right? So I'm not actively shuttling it outside of the cell, so levels would increase, right? So now you have increased sodium concentrations in the cell. The other thing you're going to see is that it's going to increase activity of this transporter here. This one does not require energy, basically because it's an antiporter transporter here, where it's actually going to be shuttling sodium out but bringing calcium in to the cell. So this one can start to work more. It's going to be a higher functioning transporter here, and so this brings in a lot more calcium. And so calcium, how does that help muscle to contract? Well, it actually allows for the actual contraction to occur, right? So you've gone over musculoskeletal stuff and how actin and myosin interact with one another. Right, so it's binding to your opponents, showing those active sites, so that way actin and myosin can act together and they can contract, right? You have to have calcium around. And normally where's a lot of calcium stored within the cell? Sarcoplasmic reticulum, right? So you need to have calcium coming in because that helps the heart to beat stronger, helps muscle to contract stronger. So more calcium in the cell means the heart's going to contract more strongly. The contractility is going up, and we said that our problem with CHF patients is contractility is decreased, right? So the idea here is you're going to give this to help increase contractility of the heart, make it beat harder. Does that make sense? By increasing calcium, even though we're affecting a different pump that really has nothing directly to do with calcium. I really hate these tables. I think it's because I upgraded to PowerPoint in 2016 or something. It just doesn't like it. The old ones work. Not a hitch. Any questions so far? All right. So anyway, so the old mechanism, I was kind of talking about here, we're increasing contractility. We realize that this can be useful, but it's not going to be the main thing we're shooting for. Nowadays, what we see, we have this neurohormonal pathway where basically it's helping to decrease sympathetic activity, increases parasympathetic activity, which what does increased parasympathetic activity in the heart do? Decrease heart rate because it's acetylcholine on those muscarinic receptors, right? So it helps to decrease heart rate a little bit. It's going to help to resensitize those baroreflexes. You guys remember those baroreceptors? What do? They detect pressure, right? When you have a chronically hypertensive patient, those get reset to a kind of a new high point, and which is not good because that way the body thinks that, hey, having a blood pressure of 170 over 100 is normal, and that's not really normal for most people, right? So it can help to reset that, and it will also decrease some renin and angiotensin systems as well. Those are all good. And you can see this by, it's still affecting the same pumps here, but just in different cell types. You can see in those baroreceptors, you can see it, with the increased parasympathetic activity on the AV node, on the conduction system. So again, all these things are good. What you'll find is that digoxin is good for helping with symptomatic management of these patients. It'll help their exercise tolerance. It'll help them to get around a little bit better, but it does not improve mortality. At least in the studies that we've done, that we've seen, not really any benefit for mortality. The other thing is it can have a lot of toxicity associated with it, and so because of that, it has a very narrow therapeutic index, which means we have to do monitoring for it, right? So we have to monitor for levels, and again, you don't have to memorize the levels specifically, but usually we shoot for like 0.5 to 1 nanograms per ml, so it's a very small amount they're actually giving. Digoxin doses are normally in the microgram range anyway, so you don't need a whole lot in order for it to work. But what you see is you have too high concentrations, you can end up having worsening heart failure symptoms, because basically causing like bradycardia, decreased cardiac output is no good for those patients. You have to be careful with that. So again, no survival benefit, but it does show to improve quality of life, decrease hospitalizations, lots of other good things. So this is one of those things where a patient's on an ACE inhibitor, they're on a beta blocker, they're still having symptoms. This is where digoxin can come into play, right? Again, if you're having edema symptoms, if you're having fluid overload symptoms, obviously diuretics are going to be the first line for that, but digoxin can be useful. Again, no evidence for slowing that disease progression, but again, you can utilize it to help kind of tune up patients to make sure they're kind of getting kind of optimal effects here. All right. So the toxicity, you can see lots of GI effects with this, a lot of nausea, vomiting, anorexia. And then one of the other big things you can note for, and you should educate patients on to know if their levels are too high, because again, this is another drug that's renally eliminated, so if they have renal dysfunction, you got to watch out for that, which can be a common comorbidity for these patients. But they can have blurred vision, they can have this xanthopsia. Anyone know what that is? If I said cyanopsia, you know what that is? Okay, so the color's messed up. What would cyanopsia be? Yeah, it's gonna be blue. Do anyone know what xanth is kind of a prefix for? Yellow, yeah. So xanthopsia can be a yellowing of the vision. You kind of get these halos around lights, kind of yellow greenish kind of vision changes. And so if you ever hear that, that is something that should be triggering you to think, hey, they might have digoxin toxicity. It's very kind of hallmarks sort of side effects for that drug. So also you can see some CNS effects as the levels climb. You can see delirium, confusion, dizziness, all kinds of issues there. So be really careful. These older patients who have poor kidney function, they're the ones more likely to hold on to it and have issues. Also, as far as direct effects on the heart, you can end up seeing lots of EKG changes that can occur here. You can have these digoxin-induced after depolarizations, bradycardia. You can induce heart block with this. So you got to be really careful with these patients, especially if they have kind of pre-existing arrhythmias or pre-existing structural heart issues. They may be more prone to these issues. Okay. Other contraindications you would see for giving digoxin, a lot of it has to do with either usually pre-existing heart issues, so they have advanced AV block. Obviously, this could worsen that. Another thing you'll see is that the hyperkalemia, we mentioned that sodium-potassium pump that is normally doing what to potassium? Bringing it inside the cell or outside of the cell? Bringing it inside the cell, right? It gets the concentration gradient. So it's bringing potassium inside of the cell. So when you block that, if you inhibit that pump, where does potassium stay? Outside of the cell. So this is another thing where you can see increases in potassium. So imagine someone's on an ACE inhibitor, that's already going to be increased. They already have kidney dysfunction, that'll cause their potassium to be increased. You don't want to add on digoxin in that case if they're already hyperkalemic, because that can, again, worsen the chances for an arrhythmia. So be very careful with that. Hypomagnesemia can also put them at risk for this. Hypercalcemia, there's some issues with contractility with the heart, and can run into some issues there. And then also if you have Wolff-Parkinson-White, you guys know what that is? What is that? Okay, do you know structurally what it is? Basically, it's kind of an accessory pathway on the heart where it's basically able to conduct via a different route. Again, I'm not a cardiologist by any means, but I've seen it a few times in the ER, and it can be, there's certain drugs you don't want to use with it because it can end up causing them to go into some pretty significant ventricular arrhythmias. You got to be very careful with that. Anyway, the way we can actually, if someone did have digoxin toxicity, this is a drug we can actually use to bind it up and get rid of it essentially. And so this is going to be an antibody we actually have developed from ovine sources. You guys know what animal ovine sources are from? Not a cow. That's bovine. Ovine would be sheep. Yeah, it actually comes from sheep. So we will immunize sheep against digoxin, get the antibodies out, and then we actually chop up the antibodies a little bit to get them shorter, so we don't have an anaphylactic reaction to it. But it's nice because it will actually be able to bind up the digoxin, and the person can just pee it right out essentially. So that can be one drug you can use. They'll use if levels come back very, very high, or if they're very symptomatic, you can reverse this toxicity pretty quickly with it. So if you're here, Digiband, Digibind, those are the same drug essentially. Okay. The other drug you can use are called aldosterone antagonists. So we've already mentioned these before. The two primary ones we're going to focus on are spironolactone and naproxenone. Remember, spironolactone is cause what kind of side effects? Yeah, gynecomastia, has partial androgen activity at those receptors. So for guys, it can cause kind of more feminizing effects. For girls, it can potentially cause more masculinizing effects because it's just a partial agonist of that receptor there. So there is some mortality benefit, but it's only in a specific subset of patients, right? So this is a good kind of test question. We're like, what type of patient would be a good candidate for something like spironolactone? And so this is going to be for patients with grade 3 or 4 heart failure, so again, more progressive disease, as long as they do not have hyperkalemia or they do not have significant kidney dysfunction as evidenced by a high serum creatinine, right? So go above 2.5. This would be considered contraindications. Because again, giving aldosterone antagonists would do what to your potassium? Would increase it, right? Because again, we know that aldosterone is normally wasting potassium in order to hold on to more sodium and water, but if you inhibit that, you're going to end up holding on to more potassium. So this would raise your potassium up even further. So you need to be very, very careful with these patients. We have multiple drugs that will either lower or increase their potassium, so you got to be able to watch for that and make sure you're monitoring appropriately. Anyway, either of these would be fine to use. Usually eplerenone is a lot more expensive, so spironolactone or aldactone is kind of the first one you're going to go with there. Some of it is thought to help with this kind of neurohormonal kind of inhibition, similar to digoxin a little bit there, and then slowing some of this LV remodeling by antagonizing the effects of aldosterone. So again, some mortality benefit here. This would not be a first-line drug. This would be after they have beta blocker, ACE inhibitor on board. They have their diuretic as needed for fluid overload, maybe plus or minus digoxin depending on their symptomatology. And then if they still have that grade 3 or 4 heart failure, this may be an okay drug for them to be on, as long as their potassium is not too high, as long as their serum creatinine is not too bad. Okay, so a couple other drugs we can see being used. These are drugs that are going to be used IV as continuous infusions if you had a person who came with an acute decompensation. The goal for a lot of these patients is to try to, one, if their hypertension is kind of getting out of control, we want to decrease their hypertension, decrease that afterload that they're trying to pump against, and we want to increase contractility of the heart. Okay, a couple of different drugs we can use to help with that. So these are called milrinone and enamrinone. So you have PrimaCor and Inocor here, and basically these are going to be phosphodiesterase inhibitors, right? So these actually help to break down a cyclic AMP. Remember we talked about cyclic AMP being a secondary messenger system. This is very important in the heart because this actually helps to increase contractility. The other big thing it does is it's going to help to drop blood pressure as well. So this is kind of nice if you came in, the patient has really kind of poor ejection fraction, they're very hypertensive, and they're just not really getting that blood pumped to the areas where it needs to be. It's evidenced by hyperperfusion, poor skin color, cold extremities, things like that. Those are the patients you need to get the heart pumping stronger and get the blood pressure down. This is a good drug for that, right? You can give it as a continuous infusion, and will help on kind of both of those fronts there. So they can have a direct stimulation here. They have kind of balanced arterial and venous dilation. It will decrease afterload, increase cardiac output. So those can all be good. You're going to use these for short-term courses until you kind of get your patient stabilized, and then you'll transition them back over to try to get them on their kind of standard kind of treatment before you discharge them out. Again, very short-term use. We tried to use these long-term for more chronic use, and we actually see that patients have increased mortality. So this is why we don't use these for the long-term for the most part. You also have some risk for ventricular arrhythmias as well. When you stimulate the heart kind of directly like this, so be careful with that. Yes, ma'am.
Because these are short-term, are you going to give these on top of your other drugs, or kind of still?
So if you imagine like someone who's coming in with an acute decompensated heart failure, chances are you might end up taking them off of some of those other meds. So imagine they're coming in, their LV, their ejection fraction is down to 15-20%. You probably don't want them to be on a beta blocker right then, right? That's one thing I can discontinue that acutely, right? So I can get them back on that and can get them started back on that before they get discharged. ACE inhibitor is probably fine to keep on at that point, but you're kind of taking everything into account, deciding what should I keep on for right now. That's why MedRec is so important, right? Because when you're admitting a patient to the service, you got to figure out, well, what do I want to continue? What do I want to discontinue for now? And if you goof that up, patients can continue on a therapy that may have ended them up in the hospital in the first place, right? So we've seen that several times. Maybe the doses get transcribed wrong by the nurses or something. Lots of errors can come up. So MedRec, super important. If you're on any kind of admitting service in the hospital, be careful with that, right? All right. So what if you had a patient who came in and they were hypotensive and they had a poor cardiac output? What could we do for them? Well, we have other drugs for that as well. So have you guys heard the term vasopressors? So these include things like epinephrine, these include things like norepinephrine. These are, again, things we're going to be giving via continuous infusion, typically in the hospital. And so we have a couple of drugs here. One of them is going to be called dobutamine. This is a drug that is going to be selective for just activating the beta-1 receptor in the heart. So we know that if we activate beta-1, what does that do for us? Increases, well, so what does the beta-1 effect have on the heart? Speeds up the heart, so the heart's going to be beating faster, but it's also going to be beating stronger, right? That's the other big issue with these patients. We're getting cardiac output back up. So dobutamine is a good option for that. Another one we can use is another drug called dopamine, which obviously you guys are familiar with dopamine, something that our brain secretes all the time, right? This dopamine, when we give it via the IV, it doesn't really cross the blood-brain barrier so well. So it's not like you get high or euphoric off of this kind of dopamine. But what it does do is at high enough doses, it will activate beta receptors, beta-1 receptors primarily, and then even higher doses than that will activate alpha receptors. What do alpha receptors do in the vasculature? Vasoconstrict, yeah. So if you had a patient who's hypotensive and they had poor cardiac output, you could actually put them on dopamine and actually get their blood pressure up and increase cardiac output, right? So you're kind of looking at your patient to see, well, what kind of drug would they benefit most from? Is it just an issue of cardiac output and they're still hypertensive? I could use something like amrinone. I could use something like dobutamine. But if they're hypotensive, cardiac output's bad, I can use something like dopamine to get a little bit more balanced effect there and get both of those up. So again, you're taking everything kind of from a holistic approach. But these are things you might see being used. You might see things like a dobutamine stress test sometimes if you're ever working in a cardiology office where they are seeing how the heart responds in order, from a stress like increasing beta-1 activity. Looking at things like troponins, looking at the EKG, things like that to see how the heart's responding. It's usually these are more patients with pretty significant CHD and whatnot. So anyway, so that's it for CHF. Any questions on that? Yes, ma'am.
Is that before for the
Pleurolinone?
Caused gynecomastia,
Hmm?
but they both had
Um,
gynecomastia for the males.
Pleurolinone is much less so.
Just much less.
Yeah, your typical therapeutic dose. That's why a lot of people will switch from spironolactone over to a pleurolinone. Spironolactone's been around for forever, and it's pretty cheap for the most part, but the pleurolinone is newer and is, I'm not sure if it's generic or not, but it's typically more expensive. Okay, any other questions? You guys know what drugs your CHF patients should be on? Hopefully. Okay. Because again, the questions will come up like, if you have a patient who has a previous MI, they have diabetes, they have heart failure, what drug should they be on, right? What drug should they not be on? These are things that you're going to be having to make decisions on. And this is why we talk about them here, so that way you can see, like, well, they have hypertension, right? And you think for hypertension, hydrochlorothiazide is a good starter drug, an ACE inhibitor is a good starter, depending on the type of patient you're dealing with. But usually they have other compelling indications that will make you want to choose another drug in the first place, right? So if they have a previous MI, what kind of drug should they be on? Okay, a beta blocker, absolutely. What else? ACE inhibitor, right? So you already have 2 compelling indications. They have CHF, all the better, because now you can put them on the right drugs for that as well, right? So you can see a lot of these, they're doing double duty, right? Now, if they had like anginal symptoms, and if I wanted to control those symptoms, I could use something like a non-dihydropyridine, right? I could use something like a D-Isomer or verapamil, but drugs like that you don't want to use in a CHF patient, because that could have kind of, even though we saw some beta blockers are okay in CHF, predominantly you don't want to cause any kind of cardiodepressive effect. So we can use something or avoid things like non-dihydropyridines, because that can again exacerbate their CHF, right? But you could use a DHP if you wanted to help get their blood pressure down even further. So think about things like that. So you guys have covered cardiac physiology before, I'm assuming, right? So I'm not going to get super in depth on the actual EKG, but we will talk about where different electrolytes are going to be involved in the cardiac cycle. So I'm sure you guys, this will be a review for most of you, I'm hoping. But anyway, cardiac muscle, typically striated, so it's kind of like skeletal muscle in a lot of ways. But we'll see that certain areas have automaticity. What does that mean? It's a fire on its own, right? So without any kind of external stimulus, it's just going to fire on its own. What kind of areas of the heart have that? Right, we're going to see that some are going to be more predominant though, right? So what are the kind of most important ones, I should say? SA node, AV node, right? The bundle of His can have a slower rate than that. Purkinje fibers will have a little bit of automaticity to it, right? So those are really, really important for helping to establish a rate. A lot of the other cardiac cells are going to find, we're talking about slow response and fast response cells, but a lot of them need to have an action potential come along in order to trigger them off. And that's important because we want to make sure that we're having the electrical conduction going in the right direction at the right time, and everything can kind of beat in this kind of functional sensation they talk about, where things are able to work together. Because again, it wouldn't work if your atria contract at the same time as your ventricles, right? You have to have atria first, then ventricles, and back and forth and back and forth. So this needs to be orderly. Otherwise, if it is not very orderly, what happens? You get an arrhythmia, and then that causes you to not really pump out blood very well, and then you die, right? So we don't want that to happen. So we're going to hopefully prevent that. These intercalated discs, you guys know what those are? Those little lines there, what do they do? They allow for kind of transmission of electrical signals very well. They allow for transmission of electrolytes and things like that. So again, this is another way that the heart cells are all kind of able to communicate with one another and work very much in concert. So again, we mentioned those specialized cardiac cells, mainly the SA node and AV node. Which one of these has the fastest rate? Right. So again, if the AV node had a faster rate, what would happen? Yeah, that would end up being the kind of predominant heart rate, and that would not be good for us, right? Because the nature wouldn't really be conducted. But if you had something like an SA node was ablated for whatever reason, your AV node could still take over, and you could still have at least a somewhat functioning heart rate. You'd be bradycardic probably, but it would still, at least you wouldn't die, essentially. So those are important. So looking at this, we can see here that when you have, notice your normal EKG kind of pattern here, right? So again, the P wave is what? Atrial depolarization, right? So you can see the SA node kind of firing off, and notice here how it kind of has this gradual curve to it. That's really important. That's why it has this automaticity to it, and we'll look at why that is in a second here. But then you have the atrial muscle, which really needs an action potential to come along in order to trigger it off. So that's where you get that P wave occurring here once those cells get the signal to fire, right? And then you're going to have the AV node starting to kick off, and that will transmit down into the ventricles. And then we have our QRS, which is what? Ventricular depolarization, right? So again, I know this seems really basic. We'll get into why this is important in just a few seconds here. But anyway, so this is where we're going to get down through the heart, down to the bundle of His, to the Purkinje fibers. You're going to get that nice concerted squeeze of the ventricles from the bottom up, right? Because that's going to be the best way, most efficient way for us to pump blood out of the heart here. And so you can kind of see how that works. Again, notice here that you won't get nearly as much automaticity out of these cells, and they really need that action potential to come along. And then finally, we have this repolarization of the ventricles here, which is evidenced by our T wave, right? P wave, our atrial repolarization kind of gets covered by the QRS, but again, that's happening somewhere down in here. So anyway, so looking at them, I apologize, this is a little difficult to see, but looking at these fast response cells, these are going to be cells that do not have typical automaticity to them. These are going to be reliant on having an action potential come along to trigger them off, right? And so you'll notice they have a very kind of flat baseline resting membrane potential, usually between somewhere between -70 and -90 millivolts, right? So that's just where the resting membrane potential is. When you have an action potential come along, you're going to start off with this phase 0 here, right? So phase 0 is going to trigger off, and what's the main thing causing this to jump up Sodium is a big one, right? So we're going to see things are going to be affecting sodium. That's going to help with this phase 0. And then you have phase 1, we're going to have some outward amount of potassium, right? Because again, potassium is in a higher concentration inside the cell. When you have that leaving, that's going to drop the electronegativity of that membrane, right? And then you're also going to have some inward chloride. And of course, chloride being negative, when it comes in, will also drop that negativity as well, right? So that's where you get that little bit of a dip there in phase 1. Phase 2, on the other hand, is going to be this kind of plateau effect. And this is going to be due to inward calcium, right? So even though you have some chloride flowing in, some potassium flowing out, the primary thing you see is that calcium is coming in at a rate that will kind of balance that out, which is why you see this plateau, okay? That's really important because we mentioned when calcium comes into the myocyte, what happens after that? Right, so it releases calcium from the sarcoplasmic reticulum, and that triggers off the actin myosin to come together, and boom, you got a contraction, right? We don't want that to obviously stick around forever, because if it contracted and never released, then that's not a very good functioning heart, right? So we have to have it relax itself at some point. So calcium will get sequestered back in the sarcoplasmic reticulum. Those calcium channels close, and then we have this repolarization phase that's happening here. And this is primarily due to outward flowing potassium, right? So there's just several different channels here, but you need to have outward flowing potassium to repolarize the cell. And then once we're down here at this point, we're back at our resting membrane potential, and this is where phase 4 occurs, and this is where the sodium-potassium pump really takes over, right? This is what's maintaining that resting membrane potential. And what you see is if I were to have something that would kind of mess with this, if I had something like digoxin to block that, you can run into arrhythmias possibly by affecting that resting membrane potential, right? Okay. So again, looking just a different graphical way to look at this, we see sodium kind of coming in during phase 0. You're going to see potassium starting to flow out a little bit, some chloride coming in, and then calcium being that primary thing during that phase 2, that kind of plateau phase there, and then finally potassium is going to be leaving the cell. And again, you'll notice there's a little bit of overlap when these channels are open and closed, but just know what the predominant things that are causing each of those phases. That's the main takeaway to look at there, right? So anyway, so again, just another kind of picture that kind of shows you. Some people work better with different types of pictures here, but you notice, remember, we talked about the calcium channel blockers. Remember what type of calcium channels they dealt with? Those L-type calcium channels, right? So imagine if we were to get something to block those, like what type of drugs block these L-type channels on the heart specifically? Which ones though? The non-dihydropyridines, right? Because remember we said we can use verapamil diazoxide to actually decrease cardiac output by decreasing contractility, and you can see right here where it does that, right? So by decreasing the amount of calcium that's coming into that cell, you have less calcium getting released from the sarcoplasmic reticulum, less squeeze actually happening there. So again, you kind of go back and see like, okay, well that makes sense why these drugs cause their effects, because it's based on the physiology we see here, right? So that's why I was trying to stress this. Again, potassium is going to be really important here. Now, if I were to say delay that potassium release, say I were to extend that action potential out even longer, what part of the EKG do you think that would have the biggest effect on? What interval? So you have like your PR interval, you have your QRS interval, you have your QTC interval. Which one do you think that would affect? If I was delaying out the repolarization. The QTC interval, right? So again, when we talk about drugs that prolong QT, right? So you guys remember any drugs we had that did that? Fluoroquinolones, macrolides, lots of drugs that will do that, right? This is due to this potassium blocking effect here, right? Because they're delaying that repolarization of the ventricle, and we'll see why that can cause arrhythmias a little bit later on. But again, think about QTC prolongation, think about drug effects on those potassium channels. That's another really important thing to consider there. Okay, so we talked about refractory period. What is a refractory period? How would you explain to a patient? So I would explain it as there's a period of time where you cannot reuse the cell, reuse that cell again to cause an action potential, right? So there's what we call an absolute refractory period, and there's a relative refractory period. So an absolute refractory period means what? Absolutely cannot re-trigger that, right? So there's a period of time where nothing can come along, no matter how strong the signal is, to reset that, because the cell is just too busy doing its own thing. It says, hey, I can't really be bothered right now. I'm trying to do this action potential here, right? On the other hand, you have a relative refractory period, which what is that? Yeah, so if you have a big enough signal, that's where you can end up seeing something happen that will re-trigger that to cause a new action potential. So if you were to look at this cell here, or this picture here, you'd see that basically like the absolute refractory period would probably be somewhere from like say here when it starts the action potential, maybe to somewhere like here, right, as it's starting to reset itself. But if you were to have say a strong enough action potential come along, say somewhere like right here during this relative refractory period, you could trigger off a new action potential. Why is that a problem? Yeah, because you can see like premature ventricular contractions, you can see ventricular arrhythmias develop because of this. And so when you look at hearts that have ischemic tissue and things that are kind of scarred over, they don't conduct electricity quite right as compared to healthy tissue. And so you can see these kind of reentrant arrhythmias develop here. This is where you can see all this kind of these issues develop due to the fact that these relative refractory periods, you can still trigger off a new action potential, right? So keep that in mind as we kind of go forward. So looking at the slow response cells, these are going to be our pacemaker cells we've kind of alluded to previously. Notice here how it kind of has this kind of gradual slope in the electro potential here, right? So what does this do to? These are, that's what's happening. Yeah, so you're basically waiting to get up to a threshold point. At that point, then an action potential will start, right? Do you know what's causing that? It's due to sodium still, right? So it's due to leaky sodium channels. Basically, these are channels that will allow a slow amount of sodium to come in, and by causing that, you're going to have a gradual increase in that electronegativity. You're going to have an increase in that positivity there, that electric potential, and then once it gets to that threshold, that's where you're going to trigger it off to cause an action potential. This is where calcium coming in is going to be really important. Again, this is why non-dihydropyridines are so effective at dropping down your heart rate, because again, they are going to be decreasing that calcium influx. You're going to be slowing down the SA and the AV node essentially, and how well that's going to be conducting. Okay, the phase 2 is going to be more so calcium inward current versus a potassium outward current, right? So potassium leaving the cell causes that negativity to go down, that electric potential to go down, and it will end up resetting itself. And again, the sodium potassium pump is still working here, still helping to maintain somewhat of a normal resting membrane potential, but those leaky sodium channels are still what's going to be causing that kind of gradual increase in potential. Okay. So again, if you were to look at this, calcium you can see here causing that kind of sharp increase. And then what we'll see is that we can have effects on slowing down or speeding up the heart rate based on what we can see with affecting potassium. So we'll look at that in just a second so you can kind of see how potassium is working there. Okay, so looking at androgenic effects, right? So if we were to have, say, a bear jumped out, or say someone spooked you real good on Halloween, what happens to your sympathetic nervous system? You release norepinephrine, you release epinephrine. What does that do to your heart rate? Goes up. Well, how does it do that? Does it this way, right? So basically by affecting potassium conductance, right? So this will actually help to decrease potassium conductance, right? So that means it's going to be keeping more potassium inside the cell. So what does that do to the electric potential for these cells here now? I think more positive or more negative? Because you have more positive potassium sitting in the cell now. It's going to make it more positive, right? So that means it's closer to that threshold point than it was previously. So that means it's going to be much more close to that threshold, which means you can get there faster. That will increase your heart rate, right? On the other hand, if you were to have, say, you just ate like a big meal, your parasympathetic nervous system really overactive, and you're sending out a bunch of acetylcholine on those muscarinic receptors, you're going to see this will actually open up those potassium channels, allow more of it to flow out, which will cause the cells to become more positive or negative. More negative, and it means you're farther away from that threshold, which means you need to it takes more time for it to get up to that threshold to fire off an action potential. So you can see how it can directly affect how fast these cells, how fast their action potential are being generated by affecting that potassium conductance. Does that make sense? All right, so this is why if we have someone who's bradycardic, say they're coming in, they're bradycardic, they're not really perfusing that well, what's kind of the first line drug we can give them? Well, certainly we can give epi, right? We can give epinephrine, and that would certainly increase their heart rate. What's another drug we might give? Anyone like worked as an EMT? Atropine, yeah, atropine is absolutely going to do that because it's an anti-muscarinic, so it'll do exactly this, right? It's going to help to decrease that potassium conductance, it'll help to speed up the heart rate essentially. It's going to do it directly to these slow response cells. So, looking at arrhythmias, kind of the ways that these are going to be generated. So you can have things like abnormal impulse formation. So you can have altered automaticity. So either the SA and the AV node maybe not be conducting at the normal rate. Sometimes you can have what you call ectopic pacemakers, right? You have different areas of the cells which are now generating its own kind of pacemaker signal, which is overriding things like the SA and the AV node. You can have these kind of after depolarizations, which kind of go back to that relative refractory period we already mentioned. And then you can also have abnormal impulse conduction. A lot of this is due to things like myocardial ischemia, where you're scarring that tissue. It's not going to be able to conduct electricity quite as well as it used to, and so you can end up seeing these reentrant arrhythmias, right? So again, most of those especially the cells in the ventricle, like as an action potential is traveling through them, they're meant to not really be able to re-signal until you have another action potential come along from the atria, essentially. But if you have something like scar tissue, it slows down that conduction, you can end up seeing some of these reinsurance arrhythmias, and that's bringing into problems. Okay, so it's kind of a simplified mechanism here, but this is the primary ways that you see a lot of arrhythmias develop. So, and again, I'm not going to go over how to read these EKGs. I'm pretty good at reading PEA. You can usually pick that out. VTAC, VFib, I'm pretty good at, and then there's a couple of tox things I can pick up on. But other than that, you guys are going to be the EKG experts compared to me, so I'm not going to belabor these points. But just know that we're going to have different types of arrhythmias. They're going to be generated in different areas of the heart, and that's going to be affecting what type of drugs you're going to use, right? So an atrial arrhythmia does not get treated necessarily the same way that a ventricular arrhythmia will. And sometimes that can be really important because you can kill somebody, or it may not be that effective. So we'll talk about that as we go through. You guys know where, you ever heard of this one before, Torsades? What causes that? Prolonged QT, right? Either congenital or due to drugs and things like that. So we'll see even there, it has a very specific treatment for that. Anyone know what the treatment for Torsades is? Magnesium, yeah, so we'll talk about that a little bit later, right? So anyway. All right, so how do you treat an arrhythmia? Several ways we can do this. Huh? Anyone say have an answer? I was hoping they have like one solid, silver bullet kind of answer, like, oh, just do this and it's fine. But a lot of times it's not so easy, as you'll see. Basically, one of the big things you want to do is try to identify the kind of inciting problem, and if you can try to remove that if possible. So whether it be due to hypoxia, what can you do to fix that? Give them oxygen, obviously, yeah. So ischemia, reperfuse them, so maybe they can start delivering more oxygen to the tissue, right? They have electrolyte imbalances, so if you have hyperkalemia, try to get rid of that potassium. If you have hypomagnesemia, get more magnesium. You can do all these things. So those are kind of the primary, kind of easiest, lowest hanging fruit you can do. And then you want to try to establish your goals of therapy. So have you guys heard of rate control versus rhythm control before? So there's kind of these terms where in some cases you want to actually convert the person's abnormal rhythm back into a regular rhythm, right? So it's called rhythm control, and basically sometimes you will have, there's a couple ways you can do that. So it's one way you can convert them back into a regular rhythm. You should, all right, so you can use electrical cardioversion, right? So there's one way to do it, right? Especially if the patient's unstable, if they are coding, that's kind of the best way to do it. It's the quickest way. It's not going to feel great for the patient. So, oftentimes this is done under anesthesia, things like that. We also have chemical cardioversion. So this is where we can use these drugs to either, if it's kind of an arrhythmia that kind of comes and goes a little bit, like sometimes AFib will kind of be kind of intermittent. You can have them on a drug that will prevent that from occurring again, or you can just have them on a drug that will try to keep them in a normal, stable rhythm kind of for the long run. So that's called rhythm control. The other things you can do, if you had something like AFib, right, which AFib is just basically a very rapid atrial rate, right, that will have some conduction down to the ventricles, but it's generally kind of too fast in order to get, because you run into issues when if you were to have like A flutters, where you kind of more see that where the rate's a little bit slower, but that more of those conduction are getting through the ventricles, and then you can end up seeing kind of poor ventricular function, right? So you can do what we call rate control, where you can actually slow things down or prevent that from occurring. So that's another kind of method we might go through. And again, these are chemical means because we're actually giving drugs to make this happen, right? One of the big things you'll note with these are that anytime you give an antiarrhythmic, they themselves can cause an arrhythmia, right? So again, it's one of those kind of double-edged swords. We have to be really careful with a lot of these drugs. Similarly to a lot of chemotherapy, when you give it to treat cancer, guess what it can also give you? Secondary cancers, right? So it's kind of like, well, that was pointless, but a lot of times you can use these safely, and this is why you got to be really careful to do things like monitor for electrolytes, monitor for EKGs, and look for changes over time. But and just consider the electrophysiology of heart is a moving target. It changes over time. People are not always going to be the same from year to year. You can see that things like ischemia can alter this membrane potential. You can change conduction velocity. All these things can change over time, and so you got to be able to keep that in mind as you follow up with these patients. So we're going to find that you can affect the rhythm of the heart by affecting several different ion channels, and this is a predominant way that these antiarrhythmics are going to be working. So we can either do things like block sodium channels. If we block sodium channels, we saw that was really important in those fast response cells to cause that phase 0 depolarization. If I slow that down, then that decreases the excitability of the cell in general. That makes sense. I can do things like prolong the action potential by blocking potassium channels. That was what we kind of mentioned, that QT prolongation we can see with certain drugs. And we can do things like beta blocking or calcium channel blocking, where you can actually slow down conduction of the heart, slow down contractility, or decrease contractility by affecting those receptors, right? So there's several targets, and we're going to break these down into several categories. So we'll talk about the von Williams classification. You guys heard of that term before? Right, so we talk about class 1, 2, 3, 4 antiarrhythmics, and this is how we're going to break them down. Basically, what ion channels are going to be affecting, or what receptors they're hitting. So you'll find that class 1 are going to be our sodium channel blockers. You're going to break these down into class 1A, 1B, and 1C. And this is just going to be delineated based on how they affect the sodium channels. We'll go more into detail on that in a second. And then you're going to have class 2, which are going to be our beta blockers. We've already talked a lot about those. You're going to have class 3, which are going to be things that block those potassium channels and prolong repolarization. And then you're going to have class 4, which are going to be your calcium channel blockers. And then we'll have kind of a couple of random ones, like adenosine, like digoxin, digitalis. Those kind of fall into kind of a miscellaneous kind of category. So don't memorize all these indications. We're going to kind of go over this, and it'll become more intuitive as we look into the individual classes and kind of see how they work and how they're going to be affecting the heart. Just know that in general, like your class 1A, 1B, 1C, like your basically your class 1s and your class 3s, those are going to be more kind of all-purpose kind of antiarrhythmics that can affect either atrial arrhythmias or ventricular arrhythmias, right? We're going to kind of delineate between atrial versus ventricular arrhythmias. These are going to kind of be general purpose, right? So class 1, class 3 can work for either. Generally, class 2 and class 4, so beta blockers and calcium channel blockers, respectively, mainly just going to affect atrial arrhythmias, right? So you're never going to be fixing someone's VTAC by giving them a beta blocker. It's just not going to happen. But I can give them a class 3 antiarrhythmic. Anyone know a class 3 antiarrhythmic? Anyone heard of any antiarrhythmics before? Anyone heard of amiodarone? That's actually a very good class 3 antiarrhythmic. We'll talk about that. That can be utilized for either ventricular or atrial arrhythmia. So again, this will become more intuitive as we talk about the drugs, but those are kind of general guidelines to look at there. So looking at the sodium channel, you can see that these are going to be the sodium channels that are responsible for that phase 0 depolarization. And so they kind of rest in one of 3 states. So you can either be in the resting state, where basically they have no sodium coming through. They're basically kind of blocked off, and sodium just kind of bounces off of it, right? So this is kind of the resting state here. Once you hit that threshold, once an action potential comes along, you're going to end up having the activated state where it'll stay open for a short period of time to allow sodium in. And so we're going to see that some drugs are going to be affecting it in this state. And you have what you call an inactivated state, where you notice these gates here are still open, but there's kind of another portion of the protein that will come along and block further sodium from getting in here, right? And so we call this the inactivated state. This is during the refractory period, right? This is meant to make it so that you could have another action potential come along and have a lot more sodium flowing in than what you want, right? This is kind of a natural protective mechanism to keep the heart beating like it's supposed to. So some drugs, again, will be affecting the activated state more. Some will be more focusing on the inactivated state. We'll see how that can change the action potential in a different way. So class 1A, the way I remember class 1A antiarrhythmics is by PDQ. Those are the 3 drugs that are going to fall into that, so I think pretty darn quick at fixing an arrhythmia. That's just the way I think about it. Basically, this is going to be affecting that open channel, right? It's going to be affecting the open sodium channel. That's where it's going to be the most, have the highest affinity for it. And what this is going to do, and I apologize for the picture kind of covering this, but it prolongs the action potential, right? Because it's going to slow down the sodium coming in here, so it takes longer for this to occur. You can see how the kind of the ultimate height of the negativity or the electric potential here is going to be diminished, and also it just takes longer for this to occur, right? So it slows down the whole action potential, and it's going to be very slow to dissociate from the receptor itself. So again, it's going to have kind of a nice prolonged effect all the way throughout the whole action potential here. Okay. So quinidine is going to be the Q here. So it's going to be the first one we'll talk about. Anyone ever heard of quinine before? Quinine is the D-Isomer of quinine. Where do you see quinine? Maybe out if you're like out at the clubs at night. You ever under black light, like maybe your drink starts to glow in the dark. Anyone ever seen this? Good. You guys are at home studying. I appreciate your stellar, impeccable standards of character. However, if you maybe were celebrating one night and decided maybe you passed your pharm test and you went out to drink at a bar, tonic water actually contains quinine, and so that's why it actually glows under black light. So if you ever see like a gin and tonic kind of glows at nighttime, that's what it's from. But it used to be kind of an old school anti-malarial drug, but we also realized that it had decent antiarrhythmic properties as well. So use quinidine, that D-Isomer of quinine essentially. So actually comes from a plant called the cinchona tree, and then so again, a lot of our old drugs actually come from a lot of plant-based materials, and so that's one of them. So anyway, so again, these are going to help to slow conduction, prolongs that refractory period, right? So it makes it more difficult. That extends out that absolute refractory period, makes it more difficult for a new rhythm to kind of kick in there, and it will slow that phase 0 of depolarization. Okay. You'll also notice here it has some kind of indirect activities, and this will kind of influence both its cardiac effects and also some of the other side effects you see here. That quinidine has some anticholinergic activity, which means it's going to antagonize the effects of acetylcholine to those muscarinic receptors, which could actually increase heart rate to some degree. And then at higher doses, it actually have alpha blocking effects. And what does that do to the cardiovascular system? Affect blood pressure. it blocked alpha receptors, what did it do? Yeah, drop it. So it would be a hypotension. It could be a potential side effect here. So we can see here it's got some kind of undesirable activity affecting different receptors here. But again, when you're practicing medicine decades and decades ago, like, this is kind of one of the few drugs you had to go with. So that's what we dealt with. You'll see that it can be used as far as indications go to maintain rhythm in things like atrial flutter or fibrillation. So this is kind of the more primary places it'll be used. It can help to control ventricular tachycardia by trying to maintain that normal rhythm. And then I mentioned that conversion. So this is that chemical cardioversion from of aflutter and fibrillation back into, say, a normal rhythm. The one thing you always have to consider whenever you're cardioverting somebody is when you have kind of this little fluttering, kind of quivering atria, what has the tendency to occur there? Clots, right? Because whenever you have blood kind of pooling, you can see clots there. So it's really, really important. Anytime you're cardioverting someone like this, especially if it's kind of been sitting around for a while, is you need to give them an anticoagulant, something like warfarin, something like enoxaparin, heparin, something like that, in order to prevent the clot from further propagating, causing a stroke or things like that. So always consider, a lot of AFib patients are probably going to be on warfarin or like one of those newer anticoagulants we talked about during the last lecture, right? So things like your rivaroxaban, your apixaban, things like that. Anywho, so we don't use this drug too often anymore. And then the other thing you have to watch out for is actually a 2D6 inhibitor. And so one of the things you can see kind of clinical interactions is things like codeine. Codeine's an opioid analgesic that gets converted to morphine through CYP2D6, and if you block that, you may actually prevent it from working as well because you don't make as much morphine necessary. Affects a lot of heart medications, affects a lot of medications like psych medications. I'm not going to go into the full list here. We'll talk about that later, but just know this is a clinical indicator or interaction you may run into with this drug. So a lot of toxicity, you see a lot of GI effects with this one, so diarrhea, nausea, vomiting. You can end up inducing atrial and ventricular arrhythmia, so again, that's always the double-edged sword of these drugs. See hypotension due to the alpha blocking effect, and then also you can see some blood dyscrasias like thrombocytopenia, can be fatal in some cases. Again, you see why you don't use this drug quite so much anymore. And then there's this classic triad of side effects associated with this drug called synchonism, and this kind of goes back to the Syncona tree that it actually comes from, but it includes that tinnitus, that dizziness, and blurred vision. If you see all of that, those are kind of three classic side effects for quinidine. Also, you can see these kind of sudden arrhythmias that can develop here. So torsades can happen. If you imagine, if you're slowing down that whole action potential, that also will prolong your QT as well. And so again, you can see that risk for torsades developing there. So you got to watch out for that. Some immunologic reactions, you can end up seeing some hypersensitivity. So lots of side effects with it. But again, back in the day, this is one of the few drugs we had to treat arrhythmias. The next one in that class 1A category is procainamide, is the P in that PDQ. This one is going to be used a little bit more commonly. This is actually a derivative of procaine. Anyone know what type of drug procaine is? Anesthetic, yeah. So we'll talk about another drug, another local anesthetic that will show up a little bit later on. But this makes sense when we talk about the mechanism of that in a little bit. But it's going to be basically a derivative of that. And again, it's similarly affecting that open sodium channel, going to prolong that action potential, slow down that phase 0 reaction there. It's going to have a little bit less anticholinergic activity, less alpha blocking activity. So this is all nice because it can help to decrease a lot of the side effects you see with it. It does have this active metabolite here, which you can actually have some class 3 activities. It will also block some potassium channels. So you can see how have a little bit additional antiarrhythmic action there as well. Now we talked about acetylators before. People sometimes can be slow acetylators, fast acetylators. You guys remember what drug that affected? So someone comes like a lupus-like rash on an antihypertensive section. Might come up on a test someday. Hydralazine. Remember hydralazine is that one drug that uses an antihypertensive that can cause a lupus-like rash if you had a slow acetylator. And again, this is kind of a pharmacogenetic thing that some people are going to be slow, some people are going to be fast. This is another one of those drugs where if you had a slow acetylator, you could build up levels of procainamide and see this similar kind of lupus-like rash. On the other hand, though, if you had someone who's a very fast metabolizer, they can end up producing a lot of this NAPA metabolite and maybe end up seeing toxicity from that, and then in regards to like arrhythmias developing and whatnot. So you got to be careful either way with this one. And some of those side effects, which you'll see, usually a lot less significant than quinidine, which you'll see, but again, that lupus-like syndrome is kind of unique for procainamide, so kind of note that one there. And again, torsades is always a risk here. You see some better bone marrow suppression, but generally a lot better tolerated than you'll see with quinidine. And then disopyramide would be the third 1A antiarrhythmic. These effects are going to be similar to quinidine, but a little bit more anticholinergic activities, more negative inotropic effects, so again, helping to decrease that contractility. So again, I've never seen disopyramide being used clinically, but it's just kind of listed here just in case you ever see someone who's on it. Obviously, it can be used to treat things like ventricular arrhythmias, supraventricular arrhythmias like atrial fibrillation, atrial flutter. Those are all things that can, again, very similar indications across all the 1A antiarrhythmics here. in all these toxicities are very similar to what we saw previously. So again, kind of think of them as a group, but just note the kind of unique things we saw with quinidine and procainamide there. Okay, next up we have the 1B antiarrhythmics. So these ones are going to have a little bit different activity. These are actually going to be more affecting the inactivated channels. So that kind of third phase where it has it's been activated, but it's kind of not reset itself to the kind of the resting phase yet. And so what you're going to see is the 1Bs actually affect ischemic tissue more so than they affect kind of normal tissue, and that can be useful in what type of cardiac event. MI, right? When you're having ischemic tissue developing, again, one of the consequences of an MI could be what? Ventricular arrhythmias, right? So a lot of patients, you have those code reds that are coming in, the people who are found dead at home, found drop dead, essentially, they basically had an MI that went into VFib and VTAC in some cases, and so this can be one of those reasons why. So 1B antiarrhythmics were used for a while because they worked specifically in that ischemic tissue to help kind of restore normal conduction, and that kind of makes sense here because what you can see, it actually will help to shorten up a little bit the action potential. And again, we mentioned in that kind of that dying tissue, electricity is not being conducted quite as fast, and so you're trying to restore kind of a normal kind of conduction here by doing that. And so that can be very useful by shortening that phase 3 phase there of the action potential, and also decrease that ectopic foci automaticity, right? So when you have like a new piece of heart tissue that's starting to generate a new pacemaker sort of activity that can lead to an arrhythmia, this can help to diminish that as well, which is nice. So lidocaine is going to be the primary one here. I'm sure most people have heard of lidocaine before because that also works as anesthetic, right? So does anyone know why lidocaine works as an anesthetic? Same reason why it works as an antiarrhythmic. It blocks sodium channels, right? So you imagine nerve tissue, when you're conducting a painful signal, so imagine I lacerate my finger, those nerve signals that are transmitting pain signals have to go through action potentials, right? So it's signaling, and, go from node of Ranvier to node of Ranvier, you're signaling through these sodium channels. If I block that, if I deaden that signal, then all of a sudden I can still have the pain occurring in the finger, but the signal never makes up to the brain. Same thing happened to the heart here. I can slow down these sodium channels, and that will help to fix the rhythm problems you can see here. So again, you can see why these kind of pull double duty in that standpoint. So some indications you can use this for. In some cases, you can use it for Wolff Parkinson White. We use this in some cases for like ventricular tachycardia, or if you're having like premature beats, this can help to limit that. VFib, QDMI, this is kind of where the primary place that lidocaine got used for a while. This had to be IV because you cannot give lidocaine orally because actually the GI tract kind of tears it up. So this would be like an IV only medication we would give for these arrhythmias. This is kind of taking a back seat primarily due to amiodarone becoming a much more popular drug. And in fact, if you look at the ACLS guidelines, they used to recommend lidocaine as being kind of one of the first line antiarrhythmics that you would use there. Nowadays, amio is kind of taken over. I don't even think lidocaine is mentioned anymore in ACLS, but you have to double check that to make sure. But again, we're giving this IV, too big of a first pass effect if we were to give it orally. It's going to bind to those inactivated channels primarily, and you're going to see that again it's working more on ischemic tissue, which is why we liked it in MI. And the 1B though are really only going to be effective in the ventricular arrhythmias. It does not really affect atrial quite so much. So that would be kind of one difference between like the 1As and 1Bs as far as indications go. This would not be good for atrial arrhythmias. So the problem with lidocaine, though, is if you have, say, someone who has hepatic dysfunction, they can't metabolize the drug as well. The inability to levels, you can see CNS toxicity here. Things like drowsiness, confusion, nystagmus. These are some of the first signs you're going to see there that, hey, we're probably getting our levels too high there. We can do some therapeutic drug monitoring, but it's not super common that we need to because, again, we're not giving this quite as often as we used to. But if you worked in specifically in a cardiology type setting, cardiac ICU or something, you may see this used a little bit more frequently. You would like in the ER or something like that. Obviously, some people can have anesthetic allergies. You have to watch out for that. And then just be careful if you have someone who has advanced age. They're more likely to have hepatic dysfunction, may not metabolize it quite so well. The other one that fits into the category of 1B is this mexilotine. This is actually an oral analog of lidocaine that we can use for similar indications. Just be aware that has very similar effects as lidocaine, and kind of think of them together. This is actually one you would use in some occasions for people who have like congenital prolonged QT. This can help to kind of shorten that up and help to reestablish, or try to prevent that QT prolongation from generating to ventricular arrhythmias or something like that. Okay, and then we have our 1C antiarrhythmics. So again, only two there in the lidocaine and mexilotine for 1Bs, and then for 1Cs, we also have two drugs here. It's going to be flecainide and propafenone, and these are going to be more affecting again the open channels more so than the inactivated ones, but they dissociate very, very slow from the channels. So stick around for a lot longer. They're kind of more pronounced of an effect than you see with the 1As, and so you can see here how it's going to help to slow down that phase 0 depolarization, to slow down conduction, and prolong that refractory period. So flecainide is, again, we mentioned blocking the sodium channels. It's going to prolong PR, QRS, QT, and that makes sense because you're blocking it basically from phase 0 on, essentially. So you're going to prolong the entire action potential there. This one was used orally for a while. Has anyone ever heard of pill in the pocket? It's one of those things where some patients can have overt symptoms of AFib, aflutter that they can feel when they have it coming on. I kind of feel those palpitations. This is one of those things where they used to do called pill in the pocket, where basically they would carry these antiarrhythmics with them, and then whenever they felt AFib coming on, they would go ahead and just take it, and that way it would help to get them back in a normal rhythm. They actually found increased mortality from that, so we don't actually do that anymore. Nowadays for AFib, we really focus more on that rate control, which is why you see a lot more beta blockers, calcium, non-dihydropyridines being used for that nowadays. But again, for historical context, some patients may still be on this, especially if they are under the care of a cardiologist or they have any kind of congenital issue, things like that. You may see it occasionally. So for instance, like on our cardiac unit, we every once in a while will have a kid who will actually start up on one of these drugs. But again, it's usually the cardiac intensivist who's managing that. Anyway, other things you could do to help prevent PVCs, that could be another indication for this as well. Other indications, if they had a sustained ventricular arrhythmia, it could be one indication to use that. SVTs, but generally only in patients without significant structural damage to the heart, they tend to have kind of worsened outcomes when using flecainide. Other one, toxicity for this one. Again, this can induce arrhythmia. So again, if you had someone who had the sodium channel blockade happening from flecainide, it can be very difficult to treat that because again, the only way you can basically reset those channels is by giving them a lot of sodium, and oftentimes we do that by giving like sodium bicarbonate. And so we've had some cases where a patient will come in ventricular arrhythmia due to something like flecainide. We have to give them a ton of sodium bicarb to try to reset those channels, but it's still very difficult to treat, and patients end up dying from this with some regularity. Again, increased mortality in MI, which is why we don't use it there ever, and see things like bronchospasm, seizures. So again, just kind of a nasty drug. We don't use it too often. And then we have propafenone, same activity here, but also has a little bit more beta blocking activity, so it can help slow conduction, slow down heart rate. But again, it can be proarrhythmic, so not used super frequently there. All right. So just nod or something or give me the finger or something if it's too loud. whatever you got to do. So anyway, class 2 antiarrhythmics are going to be our beta blockers. We already talked a lot about beta blockers. We know these are primarily going to be for more supraventricular tachycardias or arrhythmias due to the fact they're mainly going to be affecting that nodal tissue. Like SA node, AV node is going to help slow down conduction, slow down heart rate, and mainly going to be affecting that phase 4 depolarization there is a big thing. So I'm not going to go over every single beta blocker, but I'll just mention a few here just for kind of reference sake. But like propranolol, what type of beta blocker is that? A selective, non-selective? Yeah, it was a non-selective beta blocker. So again, this kind of is kind of prototypical of those non-selective beta blockers. Again, you're going to mainly be using it for, in some cases, to try to suppress premature ventricular contractions, but not used super often for that. But a lot of times we'll use it more for like atrial arrhythmias in order to help slow down the rate there to try to do that rate control kind of method I talked about. So again, SVTs, very rarely do use it for ectopic beats in the ventricles, and then again in MI, we kind of talked about that already, where watch out for patients in MI. If they're already hypotensive or bradycardic due to the MI, you don't want to give them a beta blocker, obviously, but this could be something you may consider putting them on afterwards. Again, we already know the toxicity, so I'm not going to belabor these points, but again, you guys, this will still come up and can still be relevant here. And then we have a couple of cardio-selective ones, just again for reference. Usually, normally when I do these talks, I usually have cardio broken up into kind of half and half essentially. So this is why I'm kind of like covering it all together for you guys. It just happened with this is the way the schedule works. That's why some of the stuff seems like I'm repeating a little bit, but it's usually because it was in different sections. But just a little peek behind the kimono there. But anyway, so again, these are beta 1 selective, better for like asthmatic patients. Again, be careful for all the same side effects we'd see. Occasionally, we'll actually use a drug called esmolol. I've mentioned that previously. The brand name for that is called Brevibloc. It's a very short-acting IV beta blocker we can give. It's very good for like the ICU or the ED setting, where you can actually give them a bolus of it up front, get the heart rate under control, help maybe drop the blood pressure a little bit, and then you can titrate it very nicely. Because that's such a short duration of action, it's very quick to get the steady state. So I can change my dose just a little bit, and I can see immediate response pretty much in my patients in regard to the heart rate and whatnot. So this is a very good drug to use in the IV setting. Okay, then we have class 3 antiarrhythmics. We have these are going to be potassium blockers, right? So these are going to be reducing potassium efflux. This is going to help extend that repolarization phase, right? The phase 3 is the primary thing here. It's going to prolong that refractory period, and it's also prolonging that duration of action potential. Primary thing that gets affected here is the QTC, right? QRS is going to be extended a little bit, but it's mainly basically the S to T intervals. The main thing that's going to end up getting prolonged there, but you measure it as a QRS essentially, or Q to T. Now, amiodarone is kind of our primary drug that we're going to use in this category. It's actually an analog of thyroid hormone, which will be important when we talk about some of the side effects in a second here. Very, very long half-life drug. It can range, an average of 40 days. It's not 40 hours, but 40 days. And so because of that, it has such a long half-life, what do we need to do to get to half-life quicker? Yeah, we give a loading dose essentially, right? So we give them a big loading dose, and that way it gets the levels up a lot quicker, much faster, and that way you can do, a lot of times if you have a patient who's like having a ventricular arrhythmia or a coding or something like that, we'll give them a bolus of amio, and then we'll start them on a drip if it's effective, and kind of continue that through their stay until they kind of get stable, and then you switch them over to oral use. This drug sticks around for such a long time, this is going to influence some of the side effects we'll see here in just a few minutes. But again, usually these indications are going to be for trying to treatment-resistant arrhythmias, ventricular arrhythmias. If you try to treat AFib or A-flutter and the main drug you're using is not working, you can go back and try amiodarone as well. So it's kind of a good fallback antiarrhythmic. We use it pretty frequently in the setting of like MI. If they're having a ventricular arrhythmia, someone's coding, like this is a really good go-to drug in a lot of cases. So if you work in the ER, get familiar with it because you'll probably see these with some regularity. So not only does it block those potassium channels, but also can have multiple effects, including things like sodium channels, block some calcium channels. So it has lots of different activities here, but primarily the big thing we're focusing on is the potassium blocking effects. Now, the toxicity is really important here. If you give too much of it too fast, you can certainly see some bradycardia, hypotension that can happen very immediately, but it's more the long-term, like the patients who have been on it for several years, the effects that we're worried about. So you can see things like pulmonary fibrosis. This can actually be fatal, so you got to watch PFTs in these patients over the long run. You can see things like neuropathies, muscle weakness due to the neurotoxicity. You can see with it. You can even see a blue-gray skin discoloration. So if you ever patients have kind of this kind of ashy-looking kind of skin, like a lot of it can kind of go back to this deposition of amio in the skin. That may or may not be reversible depending on how long you've been on it for. You have vision problems, you have corneal deposits can affect their vision, and then you can also either see, due to that thyroid analog, you can see either hyperthyroidism or hypothyroidism. So again, another thing you want to watch for, monitor TSH and T3, T4 levels, etc. Just be aware of that. Watch out for other drug interactions as well, either both pharmacodynamic in regards to other antiarrhythmics, or in some cases you can see some kinetic interactions where you can actually see an increase in digoxin levels, warfarin levels, etc. So again, it's a very effective drug when used appropriately, but you got to be careful of these side effects in drug interactions. Another one's called ibutylide. So again, it's going to be working to block those potassium channels, helps prolong repolarization, prolongs action potential. Very similar effects to what you see with amio. This one can be used IV as well. This can actually be used to control atrial flutter or fibrillation. This would be one of those things where you can use it for that chemical cardioversion to convert them back over to a normal rhythm. But again, worry about some of these toxicities, including things like torsades, heart block, that can be relatively common. Okay, and this is actually another very clinically important one. My wife works over at ORMC, and so this is actually a big one that a lot of the cardiac service will start patients on. It lacks a lot of the toxicity that amio has. This one's called difetilide or Digoxin, and so she has to do a lot of Digoxin counseling. It's one of the things you have to, obviously worry about with your patients is you educate them appropriately to make sure they're not going to have it run into issues. Because again, these drugs can be very deadly, right? They goof up their electrolytes, or they take too much or too little, like can all lead to an arrhythmia. It can, kill them essentially. But this one's a pure potassium channel blocker, and so what this can do is help to maintain normal rhythm and atrial fibrillation. That's the primary indication a lot of people get put on this for. Sometimes as an alternative to amio because it lacks a lot of those kind of nasty side effects we talked about with that. And it has to actually, you have to go through special training in order to get certified to use it. So it's kind of similar to those REMS programs we talked about before, like with Accutane, like you have to register the program. This one requires special training, so you know the dangers, you know the things to monitor for to make sure you don't accidentally kill somebody. So that includes like monitoring things like the magnesium, looking at their potassiums. You have to monitor electrolytes. You have to monitor renal function to make sure they're not holding on to the drug or their electrolytes don't get goofed up from that. So very, very careful with this one, but can be very, very effective. Obviously, torsades being a big risk here. You see pretty significant QT prolongation. So obviously, you're going to be monitoring kind of pre and post EKGs and making sure you're not seeing too significant of a change. You know where like a normal QTC is? So about 440 or so. Who has a longer QTC, males or females? Females have a little bit longer actually, so they might have like 450 or so. So think about things like if their QT is getting up to like say 500, maybe you might be a little concerned once you start seeing like, and I worry about this a lot with a lot of overdoses we run into, especially with a lot of the psych meds we'll talk about next semester. Like a lot of those prolonged QT, a lot of patients are on multiple ones. So like when I see a QTC like 550, 600, that's when I'm starting to get like concerned for torsades popping up. I've seen it happen just a few times, but anyway, we'll talk about the way we can treat that in just a little bit. But again, be very careful with this one. Again, monitor that renal function, monitor electrolytes like magnesium and potassium, especially because if those are out of whack, they can definitely lead to an arrhythmia. And then we have Sotalol. What type of drug is Sotalol? It's a beta blocker. Did I just goof up my slide order? No, I didn't. Not this time. I usually do, but not this time. So this is actually a beta blocker. It actually has some class 3 activity. So it actually blocks potassium channels in addition to being a beta blocker. So this is why it gets a class 3 indication here. So again, by doing that, not only can you slow down AV, SA nodal conduction, slow down heart rate, but this will also affect that phase 4 repolarization by blocking those potassium channels. So again, you may use it for things like aflutter, AFib, or in some cases, prevention of ventricular tachyarrhythmias. Again, similar things to watch out for: torsades, monitor that QTC. Again, this one's a non-selective beta blocker, so you have to worry about things like bronchospasm and those patients with reactive airway disease. Let's see. Okay, then finally we have our class 4 antiarrhythmics. These are going to be our calcium channel blockers. Now, are these all the calcium channel blockers? No, which ones are they? These are the non-dihydropyridines, right? So there's going to be your verapamil, diltiazem. These are the only two that kind of get considered to be a class 4 antiarrhythmic. The other ones work on the blood vessels, right? They're going to be causing a decrease in blood pressure. That's the primary thing they're used for. But again, they're affecting those L-type channels. They're going to slow down AV nodal conduction, and they're going to have a negative inotropic effect here. So these are really good for supraventricular arrhythmias. So if we have someone who has like SVT or PSVT, like paroxysmal supraventricular tachycardia, this is something that we can utilize this to help slow down that rate. Because again, the issue is when you have the atrius sending down such a fast rate, if the ventricles are trying to beat too fast, they end up just getting very inefficient. They start to quiver. They can't really fill very well, and that's where you run into problems, right? That's when they get kind of unstable. And this is very good to help slow down that conduction through the AV node. That way you can have the ventricles working a little bit more efficiently. So this is a good go-to drug you'll use. A lot of EMS rigs will carry this, one of these two, in order to treat those patients if another drug doesn't work, which we'll see what that is in a second here. But anyway, so again, we know all the side effects associated with these drugs. We know to watch out for like 3 or 4 interactions. We know to watch out for bradycardia, hypotension. You can see with all these as well. So again, AFib, PSVT are the primary indications. You might use it as an antiarrhythmic, but you can watch out for hypotension, watch out for that edema, all that stuff we talked about previously. Okay, so we have a couple of miscellaneous agents here. I'm probably only going to focus on adenosine, digoxin, and magnesium here for our purpose. I don't have slides on these. We'll see. We'll find out. Anyone ever used adenosine before?
SVT.
Use it for SVT. Anyone ever seen it given before? Super cool. If you get a chance to watch it, it's very, very neat. Basically, adenosine receptors in the body, either in the brain or in the heart, act as like kind of the emergency brakes in your car, right? So normally we have things that can kind of slow down the heart. We have things that can slow down the brain, but these are going to like put a kind of an immediate stop to things, essentially. So when you give adenosine, if I were to give, say, a continuous infusion of it, it would basically shut the heart down completely. It would just go into PEA and they'd be dead, right? We're doing this for a very short, brief period of time to try to reset the heart, right? So if they have a PSVT, is supraventricular arrhythmia, we can slow down things. We can kind of reset the heart, shut it down. It's kind of like turning off your computer and turning it back on when it's not working right. Same factor we're doing here. So the drug has a very short half-life, only around 10 seconds or so. So by the time you get it into the system, get it to the heart, it's going to metabolize very quickly, and then it's gone out of it. That's why you can see that they'll have that kind of brief period of PEA for just a few seconds or so, and they come right back. And so when you give this, you're usually monitoring the patient on like a continuous EKG. You can see they're going, heart rate's at 180, 190, beat, 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 and then they'll stop for a second, and then hopefully they'll come back in a sinus rhythm. Not always. Sometimes they'll come back in the same rhythm as before, but the idea is you want to break that SVT if you can. You guys know any other ways to break SVT? Try to induce the vagal nerve, right? So you can, yeah, you want to bear down. You have them like breathe through a straw. That can help. that increased pressure can help to stimulate the vagal nerve to increase acetylcholine onto the heart. That's the kind of one of the easier things that we can do initially. But if that doesn't work, or imagine if you're dealing with a kid and trying to get, dealing with a baby, trying to get them to cooperate, it can be very difficult, right? So a lot of times we end up resorting to using adenosine. Now, because of the half-life is so short, it's super important that we give this very, very quickly. If you don't give it quickly enough, the drug will degrade in the vein before it actually gets to the heart, and so it may lead you to using repeated doses or higher doses than you actually need to. And so what we'll do is we actually give this in a kind of a unique kind of looking contraption. But you guys know what a three-way stopcock is? Right, so basically it's got 3 ports on it. You'll have one syringe will have your drug in it. You'll have one syringe that has like 10 mLs of saline, essentially as your flush, and then you're going to have the other end hooked up to the patient. And so basically you'll have it set up, and you go push as like fast as you can to get that adenosine right to the heart, so that way it'll actually break the SVT. And so if you goof it up, you don't give it correctly, then the drug will either be ineffective, and you'll have to give another dose or try to give a higher dose. And you don't know, was the drug ineffective, or is it just because I didn't give it right? So that's another thing you watch out for. So again, SVT is the most common thing we use it for. Occasionally, if you have a Wolff Parkinson White, you may use it for that occasionally. The main toxicities are pretty short-lived, but they can be pretty dramatic for the patient because, again, you're kind of starving the heart for them for a second. And a lot of these patients are still, coherent when you do this. A lot of flushing associated with it, shortness of breath. They kind of get this burning in the chest feeling for a few seconds, and they get this kind of impending doom, kind of like you're just like stop their heart for a second or something. But that's one of the noted side effects for adenosine. So it's kind of neat. If you ever get to see it, I would recommend checking it out. We mentioned digoxin already. Talked about this being a sodium-potassium inhibitor, right? So it's going to help to increase contractility of the heart, but it will also induce kind of a bradycardia. Will slow down AV conduction, and so occasionally we'll use this as an antiarrhythmic. I will see it more commonly used either for our CHF patients, as I mentioned, or patients who are like kind of post-op open heart. They might get put on this occasionally in order to help kind of increase contractility for the heart, kind of slow things down a little bit to help it beat a little bit stronger in the post-operative setting. But you won't see as many patients being managed on, originally used for like AFib, AFlutter, a lot of cases, but nowadays we kind of moved them on over to like things like beta blockers or calcium channel blockers more commonly. So you may see people being using this for AFib, but not as often. Okay. Again, this can slow down ventricular rate, can induce heart block, which may be useful if you're having AFib or AFlutter, and all the same side effects are going to be noted here as well. So again, same things. All right, and we have magnesium. Magnesium is going to be relegated for using for torsades, typically in a big kind of 1 to 2 gram bolus, and hopefully this will correct the issue that's going on there. So essentially, magnesium acts as kind of like a calcium channel blocker. Essentially, if you can kind of think about it like a dihydropyridine almost, because again, any other indications where you can use magnesium for patients? Yeah, we use it for codes, but it's usually for like torsades. That's why we keep it in the code cards. Any other indications? If you have like a pregnant patient, anything? So you ever heard of eclampsia or preeclampsia? They have a hypertensive pregnant patient. You give them a lot of magnesium because it actually helps to relax the smooth muscle on the vasculature and bring down their blood pressure. So a lot of OB units, you'll see a ton of magnesium being used to help treat their blood pressure. It's another big place you're going to see that being used. Know any other places you might use magnesium? How about for a respiratory condition? Also use it for asthma occasionally. So if you have really bad asthma exacerbation, or if you have like status asthmaticus, we'll sometimes use magnesium because again that helps relax the bronchial smooth muscle. That's one indication. But we use it here to help treat torsades. You have to watch out because it causes a lot of smooth muscle relaxation. So you can see things like flushing, you see headache associated with it. But again, hopefully you're fixing that arrhythmia and saving their life from that standpoint. So you can probably deal with a little bit of headache. But you can't see bradycardia associated with it, so you can watch out for that. We'll typically give magnesium big boluses like that with a lot of fluid to make sure we kind of tank up the intravascular space to kind of limit the hypotension. So that's usually kind of a common thing we'll kind of give together. All right, that's the end of the antiarrhythmic section. That one slide had like phenytoin, maxillatine, or not maxillatine, whatever the other ones were on that slide. I didn't talk about it, don't worry about it. Phenytoin is actually originally was used as an antiarrhythmic, but nowadays we use it more for, anyone know what we use phenytoin for? Seizures, yeah, so we use it as an anti-epileptic. So we'll talk more about that in the neuro section, probably next semester, I think. Okay, so that's the end of the test material. It's a lot of cardio, but thankfully a lot of the drugs pull double duty or triple duty in some cases, right? So if you know things about beta blockers, guess what? It doesn't matter if it's hypertension, CHF, arrhythmias, like all the same side effects, right? all the same contraindications, all the same drug interactions. So again, just remember those things. Make sure you can look at a drug and know which kind of classification it falls into. Know if it's a dihydropyridine versus non-dihydropyridine. Know if it's a beta blocker versus an ACE inhibitor versus an ARB. Be able to kind of identify those just based on the drug name alone, right? Those kind of things that's how the test questions are written essentially, right? Yes, ma'am.
Sorry.
You're fine.
Oh, so I know last exam you gave us like a percentage of what to expect from this and that. I see you've already made the exam.
The exam is made.
Do you know how much EMT?
When I made it, I believe I tried to make it co-measure it with the amount of lecture time we're gonna have. So probably 2/3 cardio and split up the other third. It was ENT and pulm. Yeah, something like that.
Okay.
I tried to make it pretty even. But honestly, I wrote it like weeks and weeks ago, so I couldn't tell you dead to rights what the breakdown is.
Thanks.
No problem. Any other questions I can answer? Okay, try to get your emails and questions to me as soon as possible. More likely to get good answers. Typically midnight the night before the test. Not very likely to get a good answer. Or if I'm awake to write an answer, I'm probably not going to be very coherent to do so, because I'm probably up with the baby. So. All right, if not, I will see you guys next week.
See you.
Don't forget the assignment. Turn that in, preferably before the test day, so that way you make sure it's in and done.